Dr. Ken Landau. Thanks for watching. Let's talk about hypothyroidism, very common condition. When the thyroid hormone isn't produced in adequate amounts, the metabolism of the entire body can be thrown off. And the thyroid is just a little tiny gland that's butterfly-shaped and weighs only about an ounce, sits right in front of and just below your Adam's apple. About 2 million people have hypothyroidism in the United States, much more than who have hyperthyroidism. So hypothyroidism is the common disease. And while it affects 2 million people who have the diagnosis, it's expected that if we add in all of the people who don't have the diagnosis yet, and the people who have some mild abnormality, we're talking about as many as 10 million people, 5 to 8 times more common in women than it is in men. It's extremely common during middle age. However, during old age, if we look at people who are over 65, especially over age 80, the incidence can rise to about 1 in 20. If we look at Caucasians, if we look at Hispanics, the incidence is about 5%. Among blacks, it's less than 2%. Not everybody's at the same risk for developing hypothyroidism. Some people are at increased risk. So if you have a history of a goiter, a family history of thyroid abnormalities, or you have a history of thyroid surgery, maybe for a nodule, maybe for a malignancy. Pregnant women are at increased risk, and the risk increase remains for 6 to 12 months after pregnancy. Or some people are at risk because they have an autoimmune disease, maybe type 1 diabetes, maybe they have lupus, maybe they have rheumatoid arthritis. We know that thyroid hormone is relatively easy to manufacture. The body takes some dietary components, the iodine in your diet, and it takes an amino acid known as tyrosine, combines the two in the thyroid gland, combines them with thyroglobulin, and then you get some thyroid hormone. The only part of the body that makes thyroid hormone, obviously, is the thyroid gland. Now, most of the product of the thyroid gland is called T4, levothyroxine. That's the typical thing that is measured. That's the amount that is greatest in the circulation. 20% of the thyroid hormone produced by the gland is called T3. That's really the active component. Most of the T4, the major product of the thyroid gland, floats around in the body in the inactive form, bound to some protein, and only about 1 to 2% is active. And that 1 to 2% to be active really has to be converted into the T3, and then it can do what it's supposed to do. Now, the question is, hypothyroidism, is that just a thyroid disease? Well, for the most part, yes. 95% of the people who have hypothyroidism have a problem with the thyroid. But sometimes the problem is elsewhere. The thyroid requires input from the pituitary gland in the brain in order to make the thyroid hormone. The pituitary makes a substance known as thyroid stimulating hormone, or TSH. That's what we typically measure. That's how we decide if you're hypothyroid. Well, sometimes the pituitary has a problem of its own. It could get a tumor, a very common type of a tumor called a pituitary adenoma. And in that case, you're not going to be able to make that TSH, or you might have some other kind of a tumor, you might have some surgery on the area, or you might be taking a drug that impacts on the production of the TSH. Or the pituitary gets its information from the hypothalamus in the brain. So you could have a problem with your hypothalamus from trauma or from some sort of other abnormality or injury. And if the hypothalamus doesn't tell the pituitary, then the pituitary can't tell the thyroid to manufacture the hormone. And then there's another instance where you just don't have a thyroid. Sometimes there is a problem with manufacturing of the thyroid gland itself that can develop in children. Now, the most common cause of hypothyroidism in the country is Hashimoto's disease, named after a Japanese physician. And this is an autoimmune disease. It's where the body manufactures some white blood cells that go attack antigens or proteins inside the thyroid. It's a very common condition. It occurs not infrequently in young adults. However, it peaks in incidence in people about age 40 to 60. Now what happens is when the thyroid cells are attacked by the white blood cells, the thyroid cells already contain some thyroid hormone, and that leaks out into the circulation. So actually Hashimoto's condition associated with hypothyroidism might start off with hyperthyroidism, too much thyroid hormone. That situation can last for about 3 months. Then all of the thyroid hormone that's been stored in the thyroid gland is exhausted, and you're not producing any. And the condition can be temporary and last for a period of maybe a year, year and a half, or it can be permanent. Now, hypothyroidism in the Hashimoto's family is an autoimmune disease, and it goes along with other autoimmune diseases like the type 1 diabetes. So 20-30% of people with type 1 diabetes are ultimately going to express Hashimoto's disease, and people with celiac disease, and people with that white disorder of the skin called vitiligo, or again the people with rheumatoid arthritis or lupus, but also seems to be at increased risk if you happen to have vitamin D insufficiency, and even people who drink alcohol. Now, we can make the diagnosis of Hashimoto's typically with a blood test, and the blood test is against some of those areas where the cells are attacking the gland. We call these antigens. So we can measure the antibodies to those, and we call that anti-thyroid peroxidase or anti-thyroglobulin, very commonly done in most laboratories across the country. And that's how we make the diagnosis of Hashimoto's thyroiditis. But there's another condition that's very common in women, and in 5 to 10% of women who are pregnant or who have been pregnant and delivered, those people can develop a Hashimoto's-like condition. We call it postpartum thyroiditis. And it can occur right after pregnancy, or it can be delayed for about 9 to 12 months. And again, it starts off with hyperthyroidism, and then it goes to hypothyroidism. And that can last for several months. May be symptomatic, may not be symptomatic. Some women need treatment, some women don't need treatment. There's another condition that's much less common, and the thyroid, just like any other area of the body, can be attacked by a virus. And when a virus attacks the thyroid, then we can get something known as subacute thyroiditis. This tends to occur in middle-aged women, and it's usually associated with some symptoms inside the neck area. So maybe pain in the thyroid gland area, or maybe difficulty swallowing. And these people tend to have a low-grade fever and an increased sedimentation rate, increased blood tests showing signs of inflammation. And you can get hypothyroidism because you're taking certain kind of medicines, the most common of which are amiodarone and lithium, relatively commonly used drugs, but you could get it because you're taking Zoloft or a different kind of an antidepressant, or maybe the opioids, the narcotics that are so commonly abused these days. Maybe with Parkinson's disease medicines or anti-seizure medicines, sometimes anti-cancer medicine, or maybe you can become hypothyroid because you had surgery on your thyroid, surgery that could remove the entire gland. Let's say you had a cancer, or just one lobe. Even if you have just one of the 2 lobes removed, you still have about a 30% chance of developing hypothyroidism. Or you might have damage to the pituitary gland because you had a tumor and the doctor operated on it. And certainly we know that hypothyroidism runs in families. But overall in the world, not in the United States, but overall in the world, the most common cause is lack of iodine in the diet. Here in the United States, other developed areas of the world, iodine is added to salt. Well, unfortunately, we get too much salt. But in other areas of the world, there is no iodine that's added to the salt, and people are deficient in their iodine, and without iodine, you can't make thyroid hormone. How much iodine do you need? Well, if you're a child, teeny weeny bit, maybe 50 to 120 micrograms, not milligrams, micrograms. If you're an adult, 100 to 200 micrograms, but if you're a pregnant woman, 200, 250 micrograms. Now, sometimes a person could be born without a thyroid or a significant abnormality of the thyroid. And that leads to major problems because we know that the thyroid hormone is very critical to the development of the brain. So if the child doesn't have sufficient amount of thyroid hormone, a condition known as cretinism may develop. And even if the condition is diagnosed relatively early in life, the problem is that the brain ceases development after about age 2 or 3. So if you don't have enough thyroid hormone prior to the time you're 2 or 3, you could have lifelong impairment. Your IQ can be low, a series of other abnormalities may develop. So thyroid hormone, very important for children. What are the symptoms of hypothyroidism? Well, unfortunately, you can't say because there's such a wide variety of symptoms, most of which come on in average people. So if we look at normal people who have nothing wrong with their thyroid, 70% or more are going to have at least one symptom of hypothyroidism. What are the symptoms? They are absolutely the same kind of symptoms that you hear all of the time. Well, my hair is thinning. I'm losing my hair. Maybe I'm losing some of my eyebrows. My skin's dry. My hair's dry. I don't sweat as much. My face is a little bit puffy. I have some droopy eyelids. I have some pain in my muscles or maybe in my joints, or maybe I feel weak or I tire more easily. I have some blurred vision. I forget. I can't concentrate. I'm gaining weight. Actually, the weight gain tends to come first, then the thyroid abnormality, not the other way around as most people assume. Or maybe you're intolerant of the cold. Maybe you're constipated, or if you're a woman, maybe your menses are a little bit heavy, or you're infertile, or you're depressed, or you're short of breath, or your voice is a little bit hoarse, or maybe your ankles swell up, or your abdomen seems to be distended. Those are symptoms of hypothyroidism, totally non-specific. And sometimes there's a specific abnormality. Maybe you have a goiter, but you can have a goiter and still have normal thyroid function. Or maybe you have carpal tunnel syndrome or a nerve entrapment, numbness or tingling of the hands or feet, sleep apnea. Maybe your cholesterol is up or your bad cholesterol is up. Maybe your heart rate is a little bit slow. So none of these symptoms are specific for hypothyroidism. And as a matter of fact, if we were to find one major abnormality, it would be a slowing of the mental or the physical processes, but generally they occur over a gradual period of time. And when it occurs over months to years, you're not aware that there's a problem until after you go see the doctor for a routine examination and you get a blood test and the blood test shows that you're hypothyroid, and then they replace the thyroid. You say, wow, I didn't know that I just wasn't feeling normal. And that's typically the way the condition is diagnosed, except in those people who have surgery. So if you have your thyroid gland removed, you will know right away that you're hypothyroid. The symptoms come on extraordinarily rapidly. Well, if we look in the United States and look at pregnant women, we have an issue with the thyroid gland, not what we talked about a moment ago. But there's a different kind of issue, because during pregnancy, your thyroid gland is going to enlarge by about 10%, and you're going to have to make about 50% more thyroid hormone than normal. And it's estimated in the old days that 2 or 3% of women were going to have some sort of deficiency during their pregnancy, at least as far as the thyroid hormone is concerned. Now we think it's up to about 15% of women. Now, if you already have diagnosed hypothyroidism, you're on treatment, and everything is going along well, you get pregnant, you're going to need more thyroid hormone. So chances are it's a good idea to increase the dose, with the permission of your doctor, of course, by about 2 pills a week. So instead of taking 7 pills, you're going to take 9 pills. Not on consecutive days, of course. because now pregnant women are going to need at least 200, 250 micrograms of the iodine during the course of a routine day. If you don't manufacture enough thyroid hormone and you're pregnant, you have an increased risk of having problems with the pregnancy, preeclampsia. Maybe the offspring is going to have a lower IQ, or stillbirth, or infant death, or miscarriage, or gestational diabetes, or preterm delivery. And the amount of thyroid hormone you need varies during the course of the pregnancy. So there are different rules for what's normal in pregnant women versus women who are not pregnant. And if you have a baby who doesn't have sufficient amount of thyroid hormone and it's not diagnosed, we can have delayed tooth eruption, delayed brain eruption, delayed muscle, we can have umbilical hernias and jaundice, we can have abnormal cry, abnormal body temperature. So as a result, in developed countries, routine thyroid screening in newborns is carried out on a regular basis. Now, how about screening other individuals? Well, the United States Preventive Services Task Force, that sort of sets the official guidelines for the country, says we don't have enough evidence to say yes or no. And the United Kingdom and Britain, the Royal College of Physicians says exactly the same thing. But the American Thyroid Association says test everybody at 35 and every 5 years thereafter. And additionally, if you happen to be pregnant, have radiation therapy, or if you're over age 60. American College of Physicians says, well, if you have a risk factor and you're over age 50, American Academy of Family Practice says, well, if you have a symptom or a risk factor and you're over age 60. The Society of Clinical Endocrinologists, they say test all women, test them even before they get pregnant, and certainly when you are pregnant, you need a test. And certainly if you happen to be taking amiodarone, or if you have lithium prescribed for some reason, or if you have a family history of abnormality, or if your cholesterol is elevated, you're infertile, you have other kind of disease, not a bad idea to get some thyroid screening. How do we screen for the thyroid? We do something called a TSH test. The TSH is the chemical that tells your thyroid, hey, make hormone. That comes from the pituitary gland. We measure it routinely. That normal is between 0.4 and 4.0, 4.2 units. It varies depending on the laboratory. But the overwhelming majority of people, 80% of the population, has a TSH of less than 2.5. About 10% of the population have a TSH in the upper limit of normal. And that leaves about 10% of the people who have abnormal TSH. Mostly it's too high, and that indicates hypothyroidism. When the TSH is too low, that indicates hyperthyroidism. Now, the TSH varies significantly. It varies with medical illness, psychiatric illness. It varies so greatly that it's suggested that if you have any kind of an acute illness, or if you're in the hospital, don't do the TSH test, because chances are it's going to be abnormal. Now, additionally, we have another issue that we have to face, and that's with subclinical hypothyroidism. So that TSH could be too high, but your thyroid hormone might be normal. And that's a relatively common condition. In fact, that's as common or more common than hypothyroidism. So your TSH is elevated. Now we have to measure the T4, the free T4, to make sure it's okay. And it often is. So no treatment is necessary for those individuals. And it's especially important to realize that this is an extraordinarily common condition in seniors. And if the seniors get treated, they have an increased risk of mortality, increased risk of death, increased risk of osteoporosis, increased risk of heart disease. So just because a person has an elevated TSH doesn't necessarily mean that they need treatment unless the T4 is low. And the TSH changes, as I said, with any kind of medical disease, and it also happens to be lowest in the morning, highest in the afternoon or evening. It's lowest in the summer, highest in the winter. It can vary over the course of day to day, and any non-thyroidal illness can make it change. So when it comes to treatment, we have an issue. Remember I said that the normal range is anywhere between 0.4 and 4.0, 4.2, something like that? Well, in you, as an individual, your normal range might be 1.0. But on therapy, we might have it at 3.0. We don't know that it was supposed to be 1.0. But at 3.0, you might say, you know, I'm taking my thyroid hormone. You say that I'm normal, but I don't feel quite right. And that might be because in that wide range of normal, people vary where they're supposed to be and where they feel better. Actually, as the TSH seems to be a little bit lower, people seem to feel a little bit better. Well, sometimes we measure the free T4, and the free T4 is the amount of thyroid hormone floating around that may be converted into the active hormone. Or we can measure those antibodies that I mentioned a moment ago, the anti-thyroid peroxidase or the anti-thyroglobulin. That gives us a good idea if you have Hashimoto's disease, but it's not definitive. Remember, because 10% of normal people can have elevation. Do we do any other kind of testing? Do we do ultrasound examinations? No, not really. Not for hypothyroidism. Do we do scans, radioactive iodine scans? No, not routinely for people who have run-of-the-mill hypothyroidism. Or how about a PET scan? Again, no. Well, what is the diagnosis of hypothyroidism? Hypothyroidism is diagnosed when the TSH is elevated and when the T4 is low, and you have some symptoms oftentimes. But how about when the TSH is elevated but the T4 is normal, or even maybe a little bit low normal? That's subclinical hypothyroidism, and we tend not to treat that. As the TSH gets to be pretty high, over 10 or so, then the likelihood of your becoming hypothyroid and having overt hypothyroidism increases. Well, the goal is obviously, if you're hypothyroid, if your free T4 is low and your TSH is high, then we begin some kind of therapy. And the kind of therapy that we begin is either with levothyroxine, the generic form, or Synthroid, the brand name form. It lasts for a relatively long time in the body, for about 7 days or so, so we don't have to take it more than about once a day. If you've had surgery and they've removed your thyroid, the amount of thyroid that replace, on average, is about 100 to 125 micrograms a day, but many people just have a little bit of hypothyroidism, so they need small amount. They might need 50 micrograms, 50 micrograms, or 75 micrograms, not uncommon. But if you get too much of the Synthroid or the levothyroxine, if we replace too much, you could become hyperthyroid. And if you become hyperthyroid, you might have insomnia, you might have an increased appetite, you might be nervous or shaky or feel hot, or you might have shortness of breath, and ultimately you could have atrial fibrillation or you could have osteoporosis. So we obviously want to begin with appropriate kind of therapy. And depending on your age, that depends on how rapidly we give you the thyroid hormone. So if you happen to be an average age of 30 or 40 or 50 and you're otherwise in good health, yeah, we'll start you on the full dose, give you 100% of what we think is supposed to be replaced, and then we monitor it over a short period of time and alter it. On the other hand, if you happen to be older or if you happen to have heart disease, we want to be very careful because we don't want to stimulate your heart too much. So we'll give you a smaller dose and gradually increase it. And remember that levothyroxine is a pre-hormone. It has to be converted into the active form. Well, there are certain specifics about taking thyroid hormone. So for instance, it hates to have food in your gut. So if you're going to take the thyroid replacement, it has to be 30 to 60 minutes before breakfast, or people are starting to take it more often at night, 2 to 3 hours after the last meal. But if you have something wrong with your gut, maybe you have a problem with your stomach, maybe you have gastritis, Maybe you have something wrong with your small intestine. Maybe you have celiac disease. Or maybe you are taking some iron supplements. Or maybe you're taking an antacid with some aluminum in it. Or maybe you're taking medicine in the proton pump inhibitor family, Nexium or Prilosec, all going to interfere with the way the levothyroxine works. So you have to be careful. Now, because there's such a narrow therapeutic index, you can get harmed with too much, you can get harmed with too little. So as a result, there are many, many different strengths that are available. You can get 25 milligram, 50 milligram, 75 milligram, 88 milligram, 100 milligram, 112 micrograms on all of the doses of those. So we know that we need to get just the right amount. Now, there is an issue that you can't switch from brand to brand. It doesn't make any difference if you go to the store and you want an aspirin. It doesn't make any difference who makes the aspirin. It's all going to be pretty much the same. But with the thyroid hormone, there is some abnormality, or some minor variation rather, in the strength, in the concentration, in the way it works in the body, in the way it's absorbed. So if you start with one brand, you should stick with that brand. Now, even in spite of all of the testing and everything else, still probably about 50% of people who are treated don't get the right kind of treatment, either too much or too little. And even after about 5 years, about 10% of the people are still hyperthyroid and 10% are hypothyroid. We have problems with inadequate dose. There's an interaction of the medicine, or maybe you're taking a medicine that's going to impact on the way the thyroid hormone works in the body, or maybe you have some kind of a concurrent illness, or maybe you're just not taking the medicine the way you're supposed to. So even after you start taking the medicine, you complain that you're fatigued or depressed, or you're still gaining weight. And the question is that from a thyroid abnormality? Or maybe you have depression, or maybe you have kidney disease, or maybe you have lung disease, or maybe you have some other kind of a disease. And it's important to realize that sometime people who are otherwise normally regulated, when the blood tests are normal, maybe there's some sort of a local abnormality in some of the tissues where the T4 isn't being converted to the T3 correctly. So we have T3, and you could take a supplement of T3 called Cytomel, and Cytomel may be appropriate for people who are otherwise well regulated but still have symptoms that might be suggestive of hypothyroidism. But remember, the symptoms of hypothyroidism can be also associated with a wide array of different kinds of diseases, from viral illnesses to lung disease or kidney disease or heart disease or neurologic disease, hypochondria. Maybe you're pregnant, maybe you're infertile for some other reason. All of those need to be considered, because remember, none of the symptoms of hypothyroidism are specific. Now, if you didn't want to take the levothyroxine, you want something natural, well, some people use desiccated thyroid, desiccated armor thyroid. And it's the ground up either cow or pig thyroid. And it's got both the T4 and the T3 in it. But it's not very popular these days because, unfortunately, it's not necessarily the same all of the time. Well, once you are on therapy and once you're well regulated, you need some more tests. If you happen to start taking a birth control pill or an antidepressant like Zoloft, or if you're taking Tegretol for your seizure disorder, or phenobarbital, or there's a significant change in your weight, and certainly if you're well regulated as a child, as you grow older, you need to have another test. And then some people, if you develop symptoms, for instance, you're taking your thyroid and all of a sudden you have some palpitations, increased heart rate, or atrial fibrillation, or you're tired, or you have headaches, or you seem to be excitable, or you can't sleep, or you have tremor, or you have angina, yes, you need to go and have another test. Now, there's a condition that we mentioned a moment ago known as subclinical hypothyroidism. And that is a confusing situation where there's a wide array of opinion, but right now it seems that for most people who just have a laboratory test, who otherwise feel well, whose thyroid hormone itself is normal, and that's even many people with Hashimoto's disease, then for them, treatment might not be appropriate. Maybe it's better idea just to do some blood tests and follow a person over a given period of time. Anyway, with that, you know pretty much what there is to know about hypothyroidism. Thanks for watching. I'm Dr. Ken Landau.